Welcome, everybody. Thank you for joining us today. We're going to give it a minute for everybody to join us and come on in and welcome to our 14th National Town Hall.
Hey, I want to take a minute and welcome everyone who's joined us today. We were going to allow a couple minutes, but we're going to go ahead and jump in because we have quite the packed agenda. It's really hard to believe that this is the National Mass Violence Center's 14th National Town Hall, and we are just so grateful for the thousands of folks who have joined us since the inaugural town hall, which was back in February of 2022. I want to start off by just introducing myself. I'm Dr. Rochelle Hansen. I am the director of the Training and Technical Assistance Division for the National Mass Violence Center, and I have the privilege of moderating today's town hall. I wanted to let you all know we have 772 registrants from 50 states plus Washington, D.C., and 7 countries around the world. So, hello, everyone. Good afternoon, good morning, good day to all of you who are here today. Couple of fun facts. 58% or 6 out of 10 registrants are in communities that have experienced a mass violence incident. Another 34% of those are those of you who have professionally responded to a mass violence tragedy. And about 6 out of 10 of you have been involved in helping communities to develop a plan, which will be a big part of what we're going to talk about today. I also want to point out that while the National Mass Violence Center hosts these town halls, we are very grateful, and we couldn't do this work without the generous support of the U.S. Department of Justice and Office for Victims of Crimes for their support for the center as well as our town halls. So I want to go ahead and welcome you to today's discussion, the continuation, or the continuum of mass violence, behavioral, and mental health services from preparedness through response and resiliency. You're going to hear from members of our own National Mass Violence Center team. So I'm super excited about that. So we'll have our staff, and we also have an expert consultant who's going to be joining us. And we will be talking about the behavioral and mental health needs of mass violence victims and survivors, as well as evidence-based practices and strategies that can help us address the important needs. A few housekeeping things I want to just make sure we're aware of. Number one, hopefully you know that this town hall is being recorded. And as you can see, we do have live ASL interpretation. So thank you to our interpreters. Closed captioning is available to all attendees. Just go to your setting at the bottom of the screen and turn on closed captions. This is available in multiple languages. After being posted to our website, the recording, slide deck, and resources will be available and can be downloaded at our site. And if you are joining us by telephone, please send an email. Link is here with your full name and email address so we can give you credit for attending today's town hall. I also want to say thank you for those of you who sent questions to our presenters in advance, and we're going to be saving some time at the end to answer the most frequently asked questions. And also, if you do have a question during the presentation, please go ahead and put it in the chat. While time is going to prevent us from being able to answer every question, we promise that we will respond through email to all questions in the chat. So want to make sure everyone's aware of that. Okay, so today we have 5 really important learning objectives. As you can see here, we're going to start off by identifying evidence-based practices and effective behavioral and mental health responses to mass violence victims and survivors, as well as resources to support their implementation. Second, we're going to describe the core elements of improving community preparedness, the TTA, ICPTTA. Specifically, we're going to focus on best practice number 11, which is about the community behavioral health response to facilitate effective planning and preparation in the event of a mass violence tragedy. Third, we're going to describe behavioral and mental health impact on victims, survivors, and community members. And this is based upon findings from an extensive survey that was done by our team. Then we'll identify effective interventions that could be utilized by practitioners at the different centers, the Friends and Relatives Center, Family Assistance Center, and Resiliency Center, as well as resources that are available from our center to provide guidance and support. And then last but not least, we're going to describe behavioral and mental health interventions that are specific to child and adolescent victims, as well as some resources for schools to provide support across the whole continuum of a mass violence incident. So we have three incredible speakers today, each of whom has extensive knowledge and lived experience in both preparing and responding to mass violence incidents. I'm going to give very brief introductions, but you can go to our town hall registration page for more information about each of our speakers. So our first speaker is actually going to be Dr. Alyssa Reingold. Alyssa is our center's Director of Response, Recovery, and Resilience. Then we have Dr. Angie Moreland, who is the Mass Violence Center Associate Director and also the Director of Improving Community Preparedness. And then we are fortunate to have Dr. Melissa Reeves, who is a consultant to our center. She is a nationally certified school psychologist, a licensed professional counselor, and past president of the National Association of School Psychologists. And finally, we are so very grateful to our two ASL English interpreters today, Heather Young and Ernest Williams. So I am very honored to be your moderator today. And without further ado, I'm going to go ahead and turn it over to Dr. Reingold, who will share some important mental and behavioral health information and resources and an overview of different terminology that's used to describe evidence-based practices. So take it away, Alyssa.
Thank you very much, Rochelle. I'm glad to be here, and hopefully we can spend an entire probably day talking a little bit about just this first concepts alone of defining some terminology. So I'm just going to hit the high points for you all so we're all sort of on the same page and you can do some more research on some of these concepts. So first before we get into talking about evidence-based interventions, I first want to talk about concepts of trauma-informed care and trauma-informed programs and services, because that's really the core of all the things that we do. And so that really needs to be at the forefront when we're talking about any interventions that we're providing to victims and survivors of mass violence. Trauma-informed programs and services include sort of 5 core concepts. Safety is that first concept. So throughout organizations, people that serve and the people we work with really need to feel both physically and emotionally safe. So not only do we need to tend to the physical settings of when we're providing services for victims, whether that is at a family assistance center or at a resiliency center or other types of centers or organizations, we really want to make sure that the physical environment feels safe to victims and survivors, but then also the interpersonal interactions that we have, that people have that sense of psychological safety as well. Trust is an important concept. So trustworthy and transparency. We need to build trust with people that we're serving. And how we do that is we need to establish relationships and we need to be transparent about kind of how we operate and what we do in our services. Choice is really important to victims and survivors. So creating opportunities for no wrong door in services and resources can be really helpful, along with collaboration. So valuing partnership with ourselves, our organizations, the people that serve, as well as partnering with the people that we serve in better understanding what the needs are, how we implement services and resources. And then last is sort of empowerment. So encourage ways to celebrate strengths, right? To celebrate how we move with healing after mass violence incidents. So resilience and healing and empowerment are all really important to foster as people learn to live with and carry this type of traumatic event with them. And so we definitely need to lean in and not just talk about how we handle and deal with the struggle, but how we also empower and strengthen wins, successes, glimmers, whatever they may be. So kind of making sure your program kind of incorporates all of those things can be really important. I also want to touch base about sort of just the spheres of where we want to look at trauma-informed care. So this approach is really meant to be multidimensional. So it can be seen not only in our organization, so making sure our organization as we approach all things are trauma-informed. Our services that we provide are trauma-informed and tailored for the victim populations we work with. And then the individual, our individual staff, our volunteers, the people, right, are committed to not only just trauma-informed care, but taking care of themselves, which is also part of being trauma-informed. So now I'm going to touch base with some kind of more meatier concepts that I know kind of gets thrown a lot around in the literature and just out there. So I want to try to disentangle a little bit some differences, some nuanced differences between evidence-based treatments or evidence-based or evidence-supported treatments, EBTs or ESTs. Those are usually synonymous. And I'll talk a little bit about evidence-based practices, which is slightly different, but very related. And I'll talk about some other terminology as well. So when we talk about, we're going to talk about different mental health strategies to support people in the recovery and the aftermath of mass violence. Treatments, interventions that are considered evidence-based treatments or evidence-supported treatments, EBTs, usually are identified as such because they've had 2 rigorous research studies that are usually evaluated through a peer review process. And that utilize what's called a randomized controlled trial to be considered evidence-based. You need basically 2 randomized controlled trials. It's usually the gold standard in scientific research. What a randomized controlled trial is, it usually involves comparing the outcomes of one treatment intervention to something else. So perhaps like another treatment, or maybe a wait list control group, if you will, for a period of time. Folks might wait and then receive services. And then folks may be randomized, so they don't get necessarily to choose, because sometimes choice influences bias of whether something will work. Although there is some research to show that choice matters in how well an intervention, how effective it can be too. So typically you would randomize folks to get an intervention. And then you're sort of comparing the outcomes of maybe the treatment condition you're interested in with the other type of intervention or wait list. And why does this matter? Why should we care about evidence-based treatments? Because we know that evidence-based treatments have been rigorously tested, and they typically demonstrate to be effective. That's not to say that other interventions might not be effective, but if they don't have some of that rigorous research behind it, we just don't know. And so typically evidence-based treatments have demonstrated that. Evidence-based treatments have been shown to shorten recovery time and result in better outcomes than usual care or no treatment at all. Failure to use evidence-based treatments can sometimes impede recovery, and in some cases could even actually increase risk of harm. So we need to be careful around that. I know there's some criticisms that exist around evidence-based treatments. One of those might be that, well, are they tested with all people? And are you hand selecting the types of people that would participate in a randomized control trial? In the trauma field, actually, that's not necessarily the case. In fact, a lot of RCTs, especially in the trauma field, typically have broadened their categories of who may participate and who've received these type of interventions that have been shown to be effective. So we have kind of the gold standard, which is our evidence-based treatments. And then we also have what are called promising practices. These are programs or interventions or approaches that have potential to be developed into best practice. Based on perhaps some early evidence, maybe they don't have 2 RCTs, maybe there's 1, maybe there's some what are other types of research that's been done with that intervention. And maybe there's been some expert judgment that also has weighed in, indicating they may be promising practices. So as I mentioned, they may not be actual randomized controlled trials, but there may be other types of studies, for instance, a case study or what's called an open trial, or other types of ways to measure outcomes. And that may indicate that intervention might be a promising practice. Then we also have terminology called evidence-informed intervention. And these usually are interventions developed that are informed by existing researched concepts and strategies. Maybe we don't have the research yet of a gold standard evidence-based treatment, but what we know from the research, maybe this is the best available science that we have, and it needs further, further investigation. We're always learning. There are always new interventions that come to the fold that people are looking at, and so this isn't sort of static. We're constantly growing and learning. And then lastly, evidence-based practice really describes, is a practice that describes integrating the available research evidence along with clinical expertise to try to help identify and solve problems for specific groups of patients to achieve sort of the best outcomes. So it's kind of combining our client perspective, our clinician expertise, and the existing research to define what's called evidence-based practice. And with that, I am going to hand it off, and you'll hear more from me when I get into more details about what that might look like along the continuum of care for mass violence. But I just wanted to set everybody on just some of those common language and terminology so we all kind of understand what they mean.
Thank you, Alyssa. I think it's really helpful to clarify that terminology because it can be so very confusing. And I do think it's also very important for people to understand the differences between an evidence-based practice versus something that's evidence-informed or a promising practice when you're making decisions about service provision. It's not to say that it's bad to be a promising practice. We just want you to be thoughtful in the decisions you make depending upon the needs of your community. And with that, I am going to go ahead and turn it over to Dr. Angie Moreland, who will be talking with you about planning and preparedness. And we can't say enough about this topic. She's going to provide you with a great overview of the ICPTTA Best Practice number 11, Enhancing Community Preparedness through Behavioral Health Response Planning. And really excited that she's going to be sharing insights from the Mass Violence Needs Assessment that has helped shed light on the behavioral health impact of mass violence. So take it away, Angie.
Thank you so much, Rochelle. So as Rochelle mentioned, I'm going to talk about best practice 11, and very much like what Alyssa was saying a second ago, we could spend an entire day just talking about this topic. And we actually do spend, weeks working and months working with communities on this best practice. But I want to just give you a 500-foot view today and kind of give you a little bit of an idea of what best practice number 11 within our preparedness framework is and what we would do in that piece, but also just really make sure to highlight the importance of preparing from a mental health and behavioral health perspective for mass violence in all communities. So for those not familiar with the ICPTTA project that Dr. Hansen just mentioned, one piece of the National Mass Violence Center, one area that we do provide training and technical assistance and work with communities on is in improving community preparedness within that community. And this community, the word community really can mean at multiple different levels. So we work with communities at a state level, at a city level, at county levels, and then we even work with, school districts, hospital systems, tribal organizations or tribal areas, and really work with them on trying to improve this preparedness across an entire spectrum. So there's 16 different best practices that we work with. We're going to talk about one of them, like I said today, and through this training and technical assistance for those interested, we can provide webinars, we can provide kind of one-stop shop types of training and technical assistance, all the way up to working with communities through all 16 of these best practices and really being able to work with them to make sure that victim services is built into their preparedness plans amongst every step and every stage of both preparedness all the way through recovery and resilience of a mass violence incident. So like I said, we're going to focus on number 11 today. And just to step back, as Dr. Hansen mentioned, and talk about why we're doing this. You can go to the next couple slides, Alyssa. So one other piece of what we've done as part of the National Mass Violence Center is conducted research, and very much like what Alyssa was talking about, the importance in research in identifying evidence-based practices. It's also very important to research communities that have experienced mass violence, both from the direct and indirect victims, really to be able to find out what's going on. So one of the components that we did from a research perspective is we went into 6 communities that had experienced a mass violence incident. And you can see on the next slide what the list of some of those communities are. And I can go into a lot more detail about this for people who are interested at another time. But we went in and we sampled almost 6,000 community members that were living within that community. And the important piece here, what we really wanted to find out is we know the impact, or at least we have a lot more research and a lot more background about the impact of direct victims. So people who were present at the scene of a mass violence incident, or those who are family members or close friends from people of people who were present at a mass violence incident. What we know a little bit less about from a research perspective is what happens to that entire community. So the people that live in town at multiple different levels of exposure, how much are they impacted by these mass violence incidents that have occurred in their community? So we looked at a range of different mental health and just general impact factors, or kind of impact different consequences or variables. One of the pieces that we looked at, next slide, is PTSD. We also really wanted to look at what people had experienced prior. So we looked at their prior physical or sexual assault, their social support, like I said, their PTSD and major depression. Also, really, what support services they used, and then how closely were they to that mass violence incident. So we know from prior literature, both in 9/11 and in a range of different mass violence incidents, that people who have closer exposure, so who were physically closer, but also emotionally closer to an incident, may be or are more impacted following a mass violence incident. So first, just to give you a glimpse of the PTSD piece, just in a nutshell, what we found is that next slide, Elsa, people living in a community that had experienced mass violence. So remember, these are not people, none of these people were present at the mass violence incident when it occurred. But what we found is that they had much higher rates of both PTSD, you can see on the left part of the slide, and depression on the right side of the slide, both in the past year and in the past month. So really our takeaway from this is the mass violence incident is not only impacting the people that were present or that know someone present at the incident, but people living in the community had double or triple the rates of PTSD and depression that we would expect in a general population. So next slide, we also really wanted to look at what is their fear. And you'll see in a second why this is really important to the preparedness piece, is that we asked them up at the top, you can see how worried were they that a family member would become a victim of another mass shooting or another mass violence incident. This first bar on the top is our national levels. So this was not our survey. This was looking at a Gallup poll that took place several years ago, really looking at how worried people are that a mass violence incident would occur in their communities. And you can see in the kind of 2 darker colors, the 19% and the 29%, that about 50% of people in the United States were fearful of a mass violence incident. Well, that second bar here, you can see that of people living in communities where a mass violence incident occurred, it's almost double that. So well, not double, but it's way higher than that. So 22.6 and 42.7%. So over 60, almost 70% of people were fearful that another mass violence incident would occur in their community. And down at the bottom, you can see we also asked about whether they would become a victim of a regular violent crime. So not a mass violence incident, but other crime that could occur in their communities. And I know that's very important for a lot of people on the call that we've talked to about just community violence in general. And you can see from the 2 darker colors on the right-hand side that over 60% of people who experienced a mass violence incident were concerned that other violent crime would happen in their community. So why is this important to preparedness? It's important to take this into account because, as my colleagues will talk about in a few minutes, really, when we talk about mental health and behavioral health from a perspective of a community, we're not only talking about evidence-based, we are always talking about evidence-based practices, but we're not only talking about one-on-one therapeutic intervention where someone's going to go into our typical definition of therapy. We really are looking at the community, behavioral, and mental health as a whole. And this really shows the importance of assessing the entire community and really making sure that we're taking a broad definition of mental and behavioral health and making sure that we're applying that lens to the entire community because it will be a spectrum. Some people in the community will need one-on-one long-term treatments to address their symptoms of PTSD or their other symptoms following a mass violence incident. But there's a range of other mental and behavioral health interventions that might also be needed for people that don't meet that kind of highest level of criteria for needing those one-on-one interventions. You can go into the next slide, Alyssa. So really these take-home points from our research show the importance of really broadening out and also knowing that one size may not fit all. And that is a huge takeaway in what we talk about whenever we work with communities and we're working on best practice number 11 is we have these best practices. We work with communities on how to prepare for mass violence, but also knowing that every community is a little bit different. And we have to take these recommendations and take these best practices and really apply them to that particular community to make sure that they're as prepped as possible. So you go into the next couple slides. I'm just going to give you a very brief overview of what we would do with a community and working through best practice number 11. So on the next slide, you'll see that the biggest piece of what we work on is really that broad community behavioral and mental health response. And those who aren't as familiar with these terms, we really do look at that behavioral and mental health, and that in many ways those are overlapping, but it's much more broad than just mental health diagnosis. So we're looking at mental health, substance use disorders, physical symptoms related to stress, overall wellness, and really making sure that communities are prepared in all of those areas, not only for to treat those mental health diagnoses, but really be able to develop immediate, short-term, and long-term response plans to address mental health across the spectrum. Next slide. So a couple of through those who have seen a couple of our last town halls, you can see that just a little bit of guidance, and my colleagues will get into this, and Dr. Reingold will in her next presentation, kind of on what you would apply at different points of the recovery process, because it's not the same from the very beginning all the way through immediate short term, all the way through the long term. Next slide. So that immediately what we're going to do, and Alyssa will talk about this, is some psychological first aid. We're really going to make sure that we have trained mental and behavioral health professionals to be able to work and to be deployed both at the Friends and Relatives Center and at the Family Assistance Center. And then in that longer term response, making sure that we have the mental and behavioral health support and referrals to those longer term evidence-based interventions, because we're not going to do those interventions right away. Those will come a little bit later. Next slide. So just a couple questions. I'm not going to go through all of this for the sake of time, but you'll see in the slide deck. And then also I'm happy to provide our overall annex that has all of this really laid out from Best Practice 11, but just a couple of things that we would ask communities in preparing for a mass violence incident to make sure that they're well prepared for mental health. Next slide. Couple of other things that we do is really talk about communication. We want to make sure that the communication is trauma informed and that we really are taking a lot of those definitions and things that Dr. Reingold talked about last, and that we're making sure people in the community have that appropriate communication to be able to communicate both about referrals and services, but also in general. And then lastly, we're going to do a subcommittee. So within best practice number 11, a lot of the best practices work that we do is much more broad than the mental and behavioral health piece. So we're going to have a subcommittee of people within that community that can really work through. And the idea is that subcommittee will form, work through the mental and behavioral health pieces, and then we'll continue to meet periodically. I would say forever. They might not be able to meet forever, but continue to meet periodically to make sure that they are up to date and continue that communication around mental health. So that was a very brief overview, a couple questions we're going to ask that subcommittee, and then I'm going to put up next, or Alyssa's going to put up next, our website. So if anyone is interested in delving more into this topic and really talking about some of that ICPTTA work, visit our website. There's a lot of the ICPTTA website. There's a lot of resources already available on there. And then also reach out if you're interested in some training and technical assistance specifically around this. So I'm going to turn it back over to Dr. Hanson. Thank you.
Thank you, Angie. I just want to highlight how important it is for communities to prepare proactively. And also a big shout out, Angie. You and your team have done so much preparedness work in communities across the United States. And I think that's just something that we really want to make sure we acknowledge publicly. And I also really appreciate the information that you share about the behavioral health impact and how much you were informed by these assessment surveys, which I just think is great. So we know that there are higher rates of PTSD and depression. But also, let's not forget that communities and individuals are really resilient, and we want to make sure that we acknowledge that as well. And I also want to lastly say that it's such a great message to understand the importance of social support in mitigating the adverse impact of a mass violence tragedy. So, huge thank you, Angie. And now we're going to go back to Dr. Reingold, who's going to talk about effective interventions for mass violence response and recovery.
Great, thank you. All right. So I'm going to just talk a little bit, orient us to back to kind of what Angie mentioned, that there, in response to mass violence, there are often, not always, but often 3 different centers that potentially could get established. A friends and relatives center, usually established in the immediate aftermath, running for 24 to 48 hours. There is a family assistance center, which Friends and Relatives Center, an FRC, transitions to a family assistance center that can provide some additional sort of response resources. It's a little bit bigger for people to connect with kind of agencies and resources and get information. That's usually open for about 7 to 10 days. Sometimes in some communities it might transition into something that's more intermittently and ongoing for several weeks. And then hopefully then it might transition into what's called a resiliency center, which is usually established within that first year at some point, and can be sustained for years on end to provide ongoing support for recovery after mass violence. So I'm going to talk a little bit about mental behavioral health interventions that could occur in each of these. It is not going to be an exhaustive list. I know I'm not going to do it all justice, but I'm just going to hit some high points for y'all to consider. If you haven't heard about some of these type of interventions or resources, then maybe you'll look into more. So typically at a friends and relatives center, that is really that first 24 to 48 hours where people are connecting, if there's surviving victims, they're connecting with family members, they're connecting with kind of resources. Law enforcement is sometimes conducting investigations. This is where potentially death notification or trauma notification might occur for those family members seeking information about their loved ones. So it's really sort of a crisis response kind of intervention that we want to do. In this type of center for community members, typically the studies have shown that psychological debriefing for community members in this type of environment may not be the best practice of choice. So just kind of bearing that in mind. There is a time and place for those types of interventions, but not necessarily for direct community members right after a large-scale mass violence incident. So just kind of bearing that in mind. So what do we know from kind of literature that might be supportive for that crisis response at an FRC? Right now, kind of what is recommended is some interventions that kind of incorporate concepts that psychological first aid has incorporated. Psychological first aid is an evidence-informed approach. Remember the terminology I mentioned before? It is evidence-informed. There right now aren't necessarily randomized controlled trials of psychological first aid in the aftermath of mass violence or disaster. Really hard to do randomized controlled trials in the immediate aftermath when you're doing crisis response, right? You're not going to necessarily pull somebody in and randomly assign them to an intervention right shortly after. So so this sort of work is evidence informed. What do we know from the research? And actually, psychological first aid was developed very thoughtfully, pulling experts, from across the world actually, to give input around both clinical experts and research experts, really doing a deep dive in the literature. What are the concepts that we know might foster recovery? And it's an evidence-informed approach to foster that initial sort of functioning, usually delivered in 24 to 72 hours after an incident. And it's developed by the National Child Traumatic Stress Network and the National Center for PTSD, and collaboratively. And there are a number of manuals in different languages, and there is a free online training course if you want to learn more about PFA. The essential concepts are really to foster sort of, we know from the literature, 5 areas that we know can help folks adapt after a traumatic event. Helping establishing safety, helping create a sense of calm and comfort, helping foster self and collective efficacy. So self-efficacy, that I can manage this. Collective efficacy, we as a community can work together to manage this. Connectedness with our supports and people, and fostering hope is also really important. So interventions that include those concepts potentially could be really helpful. And psychological first aid includes that in kind of their concepts of listening, looking at what are the basic needs, providing comfort, connecting people to their social supports, helping create some protection, physical and psychological protection, and fostering and instilling hope. There's some core actions of psychological first aid. I'm not going to go into the full details of all of these, but I just want you to be aware that there are some actions that help guide those core principles to give you some concrete tools to kind of implement. And there's some great online training tools that you can look in around PFA. Other folks have adopted PFA and kind of had other concepts that instill some of that, like sort of preparing yourself for meaning what do you need to know about this crisis event? What are the resources? Who are the populations I need to serve? What is the safety and security concerns? Listen to what people have to say. They're the ones that should be driving what their needs are, and then linking them collaboratively to what exists out there. Also want to highlight that one of our partnering organizations, the National Organization for Victim Advocacy, or NOVA, has created a crisis response team training that has been in existence for nearly 40 years, actually. They do offer some training for those that work in the victim service field to get more extensive training on how we can provide some crisis response for victims of crime, but also specifically for mass violence. Their framework kind of provides a roadmap for how to have trauma-informed conversations with victims and provide support. It's based on psychological first aid principles, and they just sort of taken those and put them to practice with some concrete training on conversations and discussion around some of those concepts. And you can find out some more information from NOVA a little bit about those trainings. In addition to the training on their crisis response approach, they also do have crisis response teams. So these are folks that potentially, when asked, so they don't self-deploy, but when asked, can help if there is a need for expanded capacity after mass violence, that they will help connect people kind of nationally and then as well as regionally. There are some states that already have created sort of their own state NOVA crisis response teams. So make sure that if you're looking to your state to see if you have those type of resources, that they can help sort of the boots on the ground in community around that. And they try, when their teams are requested to come in and assist, they do try to match some of the demographics of the community with the teams that are called to serve. So just kind of being mindful of that resource for you all. And you can I've got contact information there. You can reach out to NOVA if you want to learn a little bit more information about their crisis response teams. So that's at a family, an FRC. And then an FAC, we have a whole town hall that kind of goes through all the details of the different types of centers that you can learn a little bit more about. So I'm not going to go into details, but just for your reference. So at an FAC, we would also still do psychological first aid. It is still early on after a potentially traumatic incident for individuals. So we would still be doing psychological first aid. And NOVA's crisis response team and NOVA's crisis training also could still be implemented. If an FAC is open longer for 2 weeks, several weeks perhaps, and victims are coming in and safety has already been established, physical safety has been established, and they're coming in maybe more than once, you might want to consider evidence-informed early interventions such as skills for psychological recovery, or SPR. So skills for psychological recovery, or SPR, is also an evidence-informed intervention. Again, kind of being mindful of that language. There is some ongoing research being done on SPR with victims of crime. And actually, I would even say it's a promising practice because there is some open trials and some case studies that have done with SPR on victims of crime. SPR is not mental health counseling. Mental health providers could engage folks in SPR, but you don't have to be a mental health provider to help folks using SPR skills. The purpose is really to identify some needs immediately and teach perhaps some skills that we could potentially foster recovery in the aftermath. It's not meant to treat a problem, but really recognize people have strengths and build on those strengths and teach them skills to foster recovery. Typically can be done in one session. You would only do one skill perhaps, or you can, if you're meeting on a regular basis with the same victim, you can do that up to about 5 sessions. So these are sort of the core modules of SPR: problem solving, positive activity scheduling, managing reactions, helpful thinking, and building social connections. So how's it different from PFA? PFA is usually meant to be provided in the first few days or in a crisis response. So somebody could be in crisis response several weeks after. You might do PFA. SPR is really to help build skills during that recovery phase. So after safety and security and those immediate needs are met, then you might kind of step into doing SPR. So that can be started perhaps at a family assistance center or in that transition phase from a family assistance center to a resiliency center. And then we're going to go into kind of what are some interventions for a resiliency center? Well, there's a bunch. So I'm not going to hit them all, but I just want to highlight there are a couple evidence-based interventions for just mental health difficulties in general. Most evidence-based interventions are cognitive behavioral therapies, like exposure-based therapies, in addition to what is called third wave behavioral therapies, which include acceptance and commitment therapy, dialectical behavioral therapy. There's other types of interventions such as motivational interviewing, family therapies that can be helpful. And the goal of these evidence-based trauma-focused interventions is to improve understanding of trauma-related problems like PTSD, post-traumatic stress disorder, depression, prolonged grief, reduce distress related to that trauma, improve functioning. And there are a host of different evidence-based trauma and grief treatments. People are probably going to put in chat other ones that they know of. That these are just some examples of some gold standard evidence-based treatments. This is not an exhaustive list, but it includes things like prolonged exposure therapy, cognitive processing therapy, trauma-focused cognitive behavioral therapy for children, some examples. I do want to mention that there is also those are trauma-focused evidence-based treatments, right? So there are trauma-focused evidence-based treatments that exist. There are other types of treatments that might be trauma-focused, but may not be evidence-based. So we just want to be kind of careful. There are alternative therapies that exist, and not to say they don't work. It just means that we just don't know yet from the research whether they work or not. And so, like, if an example I usually give, if I have two pills and I say this one we know from the research is potentially effective for treating whatever it is that's ailing you, or we have this other one that tastes good but we're not sure, we think it might work, I would recommend taking the one that we know might be more effective before you try this one. If that one doesn't work, then maybe you try the other one. There's also trauma-informed resiliency interventions, and these are just not mental health treatments. These are things that can help foster just mental health well-being. So not necessarily, treating a disorder, but to provide support. Those include things like peer support, mindfulness-based strategies, physical well-being, working on your sleep, your nutrition, your exercise. We know can help your overall mental health well-being in the aftermath of trauma. These are examples of trauma-informed resiliency activities. Some might not be evidence-based treatments to treat trauma, but may foster resiliency, and they include things like art programs, music programs, yoga, things like that. And I just want to highlight real quickly, the Mass Violence Center does have a couple resources for victims and survivors. We have our virtual resiliency center at massviolence.help that talks through a number of concepts that can be potentially useful to look at, to provide support, especially helpful if your community has recently experienced a mass violence incident and there's not a resiliency center in your community. And then we also have Transcend NMVC, which is a self-help app that's free that you can download on Android or Apple that helps. It's sort of built on skills for psychological recovery. So help kind of supporting your strength-based skills to kind of help you in the aftermath. Whew, there you go. I'm going to pass it off back to you, Rochelle.
Thank you, Alyssa. I just want to again highlight that a huge focus of this part of the presentation was to help everyone have a better understanding of which interventions fit across the different phases of mass violence tragedy, and also to echo the importance of really trying to learn more about the evidence base of the interventions that you're selecting, because there are a lot of things out there that might sound intriguing or maybe are promising, but always start with the one that has the strongest empirical support. Just really want to highlight that. And our final speaker today is Dr. Melissa Reeves, and she is going to share her extensive expertise about helping child and adolescent victims, and also offer some really great tips about how we can develop school-based support programs to help kids in the aftermath of a mass violence tragedy. So take it away, Melissa.
Great. Thank you so much. It's really exciting to be here because so much of what was just talked about and so many of those approaches that was highlighted by Dr. Reingold, for example, psychological first aid, skills for psychological recovery, they mentioned NOVA training, are all of those things that really serve as the foundation of a lot of the work that we do in schools. So what I'm going to be sharing with you is specifically what can we do in schools to help those individuals that have been exposed to not only traumatic events, but actually a lot of the interventions I'm going to talk about, we can use on even a smaller scale. But a lot of the work that we're doing in schools is really what I kind of call those initial frontline interventions, that when they have been exposed to trauma, what are some things that we can do to get in there in the schools, because we have the kids for much longer than what many times community mental health providers are able to spend with them, to mitigate that traumatic impact to the best that we can. The ultimate goal, I would say, is for us to prevent them needing some of those long-term psychotherapeutic supports. But what's most critically important to all of the work that we're doing is to really help facilitate that natural recovery, so we mitigate some of those long-term negative impacts. So what I'm really going to be focusing on is based upon the Prepare curriculum. Some of you may or may not have heard of this, but it is published by the National Association of School Psychologists. We actually started writing this curriculum back in 2004, and we are now currently on the third edition of the workshops and are submitting the manuscript for the third edition of the book. And there's two different workshops that basically comprise Prepare. There is a workshop one, which is a full day training, pretty much for safety teams and crisis teams. And it really focuses on emergency preparedness. How do we build a good EOP so that we are ready to respond to different events? And actually, a component to a good EOP is providing interventions in the aftermath of exposure, but also focusing and facilitating on recovery. The second workshop we call Workshop 2 is a 2-day workshop specifically for school-based mental health professionals, so school psychologists, school counselors, school social workers, Also, we include school nurses in there, and we highly recommend, we have a network of prepare trainers across the country and also in some international locations, that they invite their community mental health professionals to the prepare training to learn the school-based interventions. So that way, in a mass tragedy, when we have our community partners that are working alongside our school mental health professionals, we have the same common foundational skill sets and we are approaching things from the same framework. So it really allows for that successful interfacing of the work that we do to help support students, staff, and families. So what I'm going to really be focusing on is information that comes from that second workshop, the one that is more mental health focused. So one of the first things that we highly recommend is, first of all, we need our school mental health professionals and community mental health professionals to have training in this school-based model because it was designed to work in schools. Early on in my training, I actually was NOVA trained, and it was a great model for community. So we took a lot of that information and how does this now apply to schools? What we talk about is the first thing we need to do is when there is some sort of trauma exposure is we need to do the triage. For so long in schools, before we had prepare, I'll be honest with you, it was bring people in, open up the big room, and just send kids down. And that doesn't work for a variety of reasons. Number one, we're going to miss kids or others that may need supports because they're not comfortable coming down. Number two, without training, our staff don't always know what to look for in regards to when do we need to refer. But also, kids, some are just going to come down because they want to get out of math class. So what we teach and prepare is through triage, and we teach different variables to look at. We need to be looking at who is most impacted that needs to be our most immediate priority. Who has been impacted, but we will get to as soon as we have available resources. And also that helps us, do we need to call in some of our community supports? And who does not need any direct crisis intervention at all, meaning their social supports are sufficient. And so we really come at this from a multi-tiered approach where we pretty much have 3 different categories of school-based crisis interventions that we provide through the Prepare model. The first level is what I just mentioned, is social supports, okay? So this is where I like to say, as mental health professionals, we're working behind the scenes. We're not doing any direct engagement with our student, staff, or parents. What we're making sure is that they are getting reconnected or reunited with those natural support systems, both at school, at home, and out in the community. The second level of interventions we have is what we refer to as psychological education or psycho-ed. So what are some things we can do to actually teach students about what are some of those common reactions you might be experiencing, and that's okay, versus what are some of those reactions where we would want you to get help for yourself, get help for a friend, or for our staff or our parents to let us know when another individual may need help. Then we have a third level of interventions, which are going to be the most intensive. And that's where we actually do engage and allow them to do some processing of what they have experienced. But also that is where referral triage would fit in. When have we done all that we can do in schools based upon the resources and the supports we have? When do we need to formally refer them out to our community mental health professionals? Now, any of you that have worked in schools know that we have what we call a multi-tiered systems of support, or a framework that is called multi-tiered, and it's in a triangle. So I always joke that every training I do, we've got to have some sort of a triangle. So when we put this into tier 1 supports, and these are supports that could be delivered universally, is that it is obviously all those things we're doing on the front end to prevent incidences from happening in the first place. So that's why we need a really good EOP. But also think of Maslow's hierarchy, that when a situation happens, we need to reaffirm physical health and perceptions of safety and security. So we teach about how we want to have good response protocols, evacuation, lockdowns, shelter in place. So because if we know what to do to get people quickly to a safe location and they're physically safe, then we can start working on that psychological safety piece. We always want to do the triage. We want to evaluate who's more impacted, who directly experienced or witnessed versus who just heard about it. Then we always want to reestablish those social support systems. And then as we move up this triangle, we get more intensive and more directive with those school-based interventions. And each one of those interventions has a protocol to follow that I'm going to quickly review in just a second. But we also really teach through the Prepare curriculum that we also need to know what are our limits in schools. Okay, what do we have the ability to provide? Hopefully mitigate as much traumatic stress as we can, but we also need to know when is it appropriate to be referring out to some of those interventions and supports that Dr. Reingold just covered. So real quickly, as we move to the next slide, to where we talk about social supports are that tier 1 universal thing that we always do. In the school safety world, the term reunification, it's bigger than just reuniting students back with their primary caregivers. We also want to reunite them back with their other natural support systems. So peers, teachers, coaches, advisors, mentors. And we know that the sooner we can get them back to a familiar environment and routine, we can lessen that traumatic impact. But we also teach through Prepare, how do we work with those caregivers, their primary custodial parents, other adults that they perceive as caregivers, our staff. How do we empower them to not only work with the students, but also some of the self-care for themselves? So that those social supports of what we would really consider tier 1, we're going to be doing that in every situation with every individual within our school community. The next level of interventions is what we refer to as psychological education. And this is literally where we are educating our school community on what are some of those common reactions to be expected? Where can you find those interventions and supports? And this would be where we are educating them on what are some of those resources that are available through the National Mass Violence Center. We may be posting links on the website, sending home informational documents. But we really want to get the information out there on kind of what to expect and where do you go if you need additional supports. Then there's what we refer to as a caregiver training. And again, what we mean by caregivers is any adult that is going to be helping students. So I like to refer to this as our staff meeting and as our parent meeting. And we have a structure that we teach within the Prepare curriculum of how do you facilitate that conversation. Before Prepare, honestly, with all my work in the schools, oftentimes I would be thrown in front of staff members or thrown in front of a parent group. And they're like, do your thing, talk to them about what just happened. And I'm like, now what we have in Prepare is there's actually a structure to these meetings to facilitate the conversation, which also lessens our anxiety as crisis responders. Then there's what we refer to as classroom meetings. These are what we call kind of our down and dirty. They're designed to be no more than about 5 to 10 minutes. Sometimes might go 15, but nowadays, social media takes over the conversation so quickly that oftentimes kids are hearing about, details before the staff even know what's going on. So instead of getting on the intercom and sharing scary information, which we say you do not do that anymore, we do not do the intercom, there are scripts that we can develop that if it's appropriate, teachers may read those to their classrooms, or we might have members of the crisis response team go into classrooms, share the facts, dispel the rumors, look at how students are responding, part of that triage, and then that directs us on who might need more. Then if we bump up to the student psychoeducational groups, this is another option. Now, we are not saying in every situation we do all of these interventions. The situation kind of guides us on which ones we do. But the student psychoeducation group is designed to be anywhere from about 40 to 50 minutes, where we actually share the facts, dispel the rumors, and we take the time to teach them about what are some of those common reactions they may be experiencing. We like to normalize that. And then what are some coping strategies that we can use? And when do we know when we need to reach out for some additional supports? So it's very much like teaching reading, writing, and math. We say now what we're doing is we're just teaching them about that trauma response and then equipping them with some basic coping strategies. Our most intensive level of intervention is what we refer to as the psychological interventions. We do teach how do we do stabilization. We also have what we refer to as a group crisis intervention, because honestly, folks, in larger scale events, we cannot individually therapize our way out of this when you have a school of 2,000 students. So we teach an intervention. We don't use this one very often, typically for those with more direct experience or exposure with the event, where they do share their story. And then we follow that up with educating them about coping strategies and what are typical responses and when do you reach out. We also, in the prepare intervention, teach how to do one-on-one supports. And then that highest tier 3 is, again, when have we reached our limits of what we can do in schools, and who are those individuals that truly need those longer term therapeutic supports, and how do we refer them out to those community resources. So just to finish up real quick, my section is that there are specifically some mental health focused interventions designed to be delivered in schools by school psychologists, school counselors, school social workers with training. Or we now have sometimes our community mental health professionals coming into schools and providing services. So there is the CBITS, Cognitive Behavioral Interventions for Trauma in Schools. There is Bounce Back, which is a younger age version of CBITS. And then there is support for students exposed to trauma that can actually be delivered by non-clinical mental health individuals. Their training for these is free. It's online. The manuals, I think all of the training is under $50. You get all of the lessons there, but it really is kind of a manualized intervention for us to deliver in schools. Then just lastly, to follow up on some of my other favorite resources to utilize in schools, is most importantly is that building resiliency and building that skill set. So if you can go to the last slide here. But early on, proactively, if we can be really focusing on those social and emotional learning skills, we are building resiliency on the front end. And then hopefully they already have tools in their toolkit when there is a crisis exposure that we can just reinforce. The zones of regulation is another favorite one of mine in schools. It is teaching students how to regulate those emotions. Komochi's is also another really good program that's out there, along with Second Step, building some of those social and emotional learning skills. There's also the aggression replacement training. And then there is a whole website on trauma sensitive schools. How do we do a trauma informed approach universally school wide? And again, all of these things are really building those skills on the front end. So in our resource slides, we do have more information on how to get access to the Prepare curriculum. There's also a book, but also some other fabulous resources. And what we really want to emphasize is the importance of school mental health professionals working closely with community mental health professionals. So when a tragedy does impact a community, we've got those relationships already established, and we are then engaging with our school community members and our students and our families, having some common foundational skill sets to really mitigate traumatic impact. That was a lot in a short amount of time.
Thank you,
Thank you.
Melissa. And I just want to say, an important takeaway from your presentation was, number one, that children's needs are very different from adults. So we can't assume that children are just, little adults or little small adult people. And then I also really love the idea of this multi-tiered model of support where you're starting with just some education and then building and addressing the needs when they are, really critical for some kids, because not all kids are going to need that high tier 3 type of intervention. So I'm going to switch gears a little bit. Early in our town hall series, attendees have told us that they love to hear from our presenters about a practical strategy or skill to help them with mass violence preparedness, response, recovery, and resilience. So I'm going to have each of our presenters share one kind of strategy or skill for you to take away from this presentation. So in no particular order, I have Angie first.
Absolutely. I think my one takeaway is that we often think about mental health being important in the recovery stages from a mass violence incident, but just really stressing that it's imperative that we consider mental health in the preparation phases so that we can ensure that the community is better prepared and that they're able to deliver those evidence-based practices to a range of populations at all of those different stages in recovery.
Thanks. How about Melissa? Oh, you're on mute, Melissa.
I always do that at least once per presentation. One of my really big takeaways is really making sure that we are training and empowering our school mental health professionals to have the skill sets to deliver some of those initial supports. But then most critical is having partnerships with entities like the National Mass Violence Center, where we can continue to expand on those school supports to our family members in the community, and build that resiliency through social supports, relationships, and connectedness, because we know that's really what facilitates that post-traumatic growth.
Thank you, Melissa. Alyssa?
Yeah, I talked a lot about mental health interventions, but firstly, not everybody is gonna, need to have is gonna struggle with mental health issues or need to have, formal mental health treatments, because people are resilient, and through some of those concepts of connection and support, that's all they may need. However, if somebody is struggling with things like post-traumatic stress or depression or prolonged grief, that there actually are some really good evidence-based interventions that do exist that can potentially help decrease people's suffering. And so I just want folks to be aware that that there are those interventions that do exist out there, and hopefully people can connect to them.
Thank you. We do have some time for a few questions that we've pulled from the ones that were sent to us. So thank you for submitting your questions in advance, and we're going to go ahead and answer a few of the ones that were asked most frequently. First question is for Alyssa, Dr. Reingold. How do states approach the ongoing decline of available and accessible mental health resources and services within their communities? So two-parter here. And then second, how do you develop and maintain a vetted roster of mental health professionals within an impacted community? Easy
So
one
we
for
Yeah, right. We probably could spend a whole half a day talking about both of those. I guess succinctly, how do we address the decline in resources, or I would actually say how do we expand capacity, right? That's the alternative. When we have declining resources, how can we figure out how to expand capacity for mental health services in communities? I think there's multiple. I think making sure we're sustaining a good pipeline for our trainees, making sure we're supporting and putting resources to train people in mental health services, in evidence-based practices at a training level. So we're increasing that pipeline, not just trainings for our existing providers, which we need to do as well. But I think we need to do that. I think we also might want to consider, how we can train non-mental health professionals, like school professionals or victim advocates or navigators or other sort of healthcare workers, other folks who interface with victims of mass violence, and how to train them up on some evidence-informed or evidence-based type of practices to support and foster recovery. So hopefully people don't need to get connected to long-term mental health. So I think that, and then addressing the vetting list, this is where preparedness is so important. Making sure at a state level, this question about how can states as a whole, states work through best practice 11, and really think through and do a needs assessment of what is the mental health capacity in their state to serve folks. If there is going to be a surge capacity for a mass violence incident, what are the resources? What does that look like? How you're going to maintain and keep a vetted list. And that takes time. That sometimes takes money. All of these things, as I mentioned, kind of potentially takes resources that need to be devoted to that. But definitely preparing. What you don't want to be doing is, when an incident happens, trying to make those calls and figure out who you're going to connect people to, and introducing yourself to people. So So just kind of having that plan, both at a state level and then also regional and even a local level, is really important, and having perhaps those lists and updating them regularly.
Yeah. I just want to echo it's so valuable
I
to
don't know if
have.
you have other thoughts on that, Rochelle.
Yeah, I was just going to say it's so incredibly helpful to have a list of professionals that are trained, and it also helps to identify where are your holes. So in the
Mhm.
preparedness, hey, this is where we really need some more training. So we have lots of professionals, for example, who are able to deliver interventions for adults after a traumatic event, but maybe we have fewer that know how to do it with kids. So why don't we proactively build up that workforce so that in the event something were to happen, we'd have that. And I'll point out that it's good either way, right? We all hope that you don't have mass violence incident in your community, but isn't it great to figure out where are there holes, where do we have great resources, and where do we need some more? So I think, you raise great points.
And I would also add a little bit in when you're kind of looking at your gaps of services, looking at kind of what your community needs are, because each community is different, right? So the folks that live in a rural area might have limited capacity. So how would you might proactively think of how you're going to serve certain rural areas of your community? Or if there's some communities that have experienced high levels of community violence already, and so they've already experienced a significant amount of trauma in their life, mass violence is going to potentially impact them just differently because of their prior life experiences. And so you also not need to kind of take some of those things in consideration when you're looking at that.
And the last thing I would add, it also gives you an opportunity to determine things like, can we deliver some services through telehealth? Can we do group treatments? Do we always have to do individual? Can we build up more what we're able to provide in school? So it really does help you to prepare in advance. And I think those are all great points. Okay, I'm going to switch gears a little bit. And this next question is for Dr. Moreland. What steps for healing and what support resources can be provided for rural communities that may lack capacity for a mass violence response? So it's a really good follow-up to our last question.
I was going to say that really builds upon what Dr. Reingold was saying. And when you're working with rural communities, especially when we're helping to prepare both on the state level and then also just all of the different levels, it's really, really important to consider what would happen if a mass violence incident occurred in a rural community. They already have, rural communities often have less resources. But even in a community that does have, even in not a rural community, a community that has a lot of resources, they still are tapped and become at their capacity to be able to provide the services needed often. So you think about that in a rural community where if they're already starting out with less providers potentially available, and by providers, I think going with what all of us have said, it's providers that are able to provide that evidence-based one-on-one treatment, but also school-based providers that may be providing those social supports or just all people that are filling in to assist with the healing of the entire mental and behavioral health response in a rural community that just might not be as available. So really building on what Dr. Reingold said is looking at those areas and figuring out how can we already build up capacity ahead of time, and very importantly, how can we rely on those partnerships? So no, it might not be available within the rural community, but how can we already start to build some partnerships where people can come in and the trust needs to be built very early. So if we can't just say, oh, well, there's, some cities nearby that have a lot of providers that could come bring people in. That's not going to be well received. And it might not be what the victims need. They really need trusted providers that know them and know their community and what they're needing. So going ahead and building that capacity ahead of time and building those relationships and partnerships to be able to figure out how can we assist one another in that entire healing journey after a mass violence incident. And as Dr. Hansen said, and if it never happens, the bad news is, or the good news is, you still have those partnerships. You've got those, and they will come in handy for a lot of other different things, as we've seen across multiple different communities.
Thank you, Angie. Another question that we're asked is how do we care for students who experience secondary trauma resulting from a mass violence incident? And are there recommended strategies to support students in a non-clinical capacity? And I know you spoke about this, Melissa, but maybe you could expound on it a little bit.
Yeah. So we talk about that a lot in schools because unfortunately, we do have a lot of communities that are exposed to trauma on a daily basis, or they have had experienced multiple traumas. One of the best ways we can do it, and I will tell you, this is not easy because it does take a universal approach and a framework. but it really is those trauma-informed, trauma-sensitive frameworks that we do in schools at a universal level. And what I mean by that is just the way you set up your climate and culture in the school, is how do we train our staff on how to look at things through the trauma lens instead of looking at it through the behavioral lens? That instead of being oppositional defiant conduct disordered, might this actually be a trauma response? And through that trauma informed, trauma sensitive approach, we can actually teach teachers, how do we set up classrooms to be more trauma sensitive? How do we approach students in a way that instead of getting in their face and demanding they do something, that we make sure that we are stepping back, that we are getting down at eye level, we are making a request, we are helping students to be knowledgeable and be self-aware of their own trauma activators. And then when they are activated, do we have cool down spots? Are we teaching them strategies to be able to manage some of those emotions? So there's actually a lot we can do in schools. And I like to say this is also just teaching life skills when we have the resources and we have leadership that supports that type of staff development for our educators, where we then can establish the trauma-informed school. And in places they're doing that, they've had a lot of not only good outcomes, but the staff are a lot happier in their jobs because they're not dealing with nearly as many dysregulated behaviors. And another huge part of that is also just building the social support systems and acknowledging that trauma exposure. But as I always like to say to my staff and kids, while we may not be able to change the past, that past does not have to define who you become. So how do we work through to really take that forward trajectory, into having a good, high quality life into adulthood? So yeah, so lots we can do beyond the scope of what I can talk about today, but the trauma-informed, trauma-sensitive approach it works really well in schools. And it also teaches about the brain. So we're also educating our staff and students about how the brain functions differently. No, you're not crazy. No, you're not a bad kid. We have to do things differently because the brain works differently when you've had that kind of exposure. So those curriculums also integrate that knowledge.
Thank you, Melissa.
Mhm.
And the last question is back to Angie. And the question is, how is the chain of command established between a local service provider like hospitals, behavior and mental health providers, victim advocates, school administrators, and federal and state authorities?
That's a great question. And I know I kind of skimmed through a little bit the subcommittee piece on best practice 11 for the sake of time. And I think that is one of the key important factors because it does differ a little bit. So it differs based on the community and what behavioral health organizations and providers and different types of services are available in that area. Also, it really does depend on the mass violence incident and what population specifically is impacted, what type specifically of event it is, and kind of how different federal pieces are going to come into play and who will be present, who will respond. And there also are just different in different jurisdictions, different kinds of points of command and different ways that they establish pieces. So that's one of the pieces that is so important in best practice number 11. And also in that subcommittee is really talking through all of those different pieces and coming up with, you're not going to come up with every single scenario of what that, line of command would be and what's going to happen, but you at least have an idea of what that would look like. And you've established that connection and that trust so that then you are able to have a plan and then pivot the plan as needed based on the incident itself and what happens around that incident.
Thank you. Well, I hope everyone will agree that this was just an incredible panel, and I feel fortunate that I got to moderate this town hall. And I want to just highlight a few things as we're wrapping up today. First, if you have any consultation, training, or technical assistance needs that we can fulfill as the National Mass Violence Center, just send us an email at the address here on the slide. And also, for every town hall, we rely upon your evaluations to help us improve their training and technical assistance, and to also give us ideas and suggestions for resources that we can provide to the field. So when the session ends, there will be a brief survey that will appear on your screen. And if you could take a few minutes to fill it out, we would just greatly appreciate your support. And in the evaluation, please include any topics that you'd like to see us address in our future town halls that we'll be doing over the next year or so. And for those of you who plan ahead, we'll pull a plug here. Our next National Mass Violence Center Town Hall will be on Thursday, September 25th, which is actually the National Day of Remembrance for Murder Victims. And the topic, which we believe is really timely, is to talk about the impact of mass violence incidents on survivors of homicide and resources to assist them. So just on behalf of our whole panel here, I want to say a tremendous thank you to all of you, and please do take the time for the evaluation. We really do take those very seriously. So thank you again.